Welcome to Knowing Your Way, a Princess Margaret ovarian cancer podcast. While the majority of women receiving a diagnosis of ovarian cancer have already gone through menopause naturally, there is a significant fraction of women who come to that diagnosis not yet having gone through menopause in a natural way. And as part of our initial treatment, surgery often induces a premature state of menopause or surgical menopause. I'm Dr. Alicia Sarabia. I'm your host today, and I've been a patient of the Gynecologic Oncology program at the Princess Margaret Cancer Center since 2015. Today, we're very fortunate to have Dr. Michelle Jacobson with us. Michelle is an obstetrician and gynecologist and a menopause specialist at Women's College and Mount Sinai Hospitals in Toronto. She's an assistant professor at the University of Toronto Department of Obstetrics and Gynaecology, and she's the director of the Familial Ovarian Cancer Clinic at the Women's College. I think we'll just start by me very briefly sharing my experience as it relates to menopause around the time of my surgery. And then Michelle will help us understand what it is that happened to me around that time and happens to so many women, and what it is that can be done about it. So as I mentioned, part of the initial treatment for ovarian cancer often, not always, consists of surgical removal of the ovaries, along with the fallopian tubes and uterus and other tissues. Prior to my surgery, I hadn't yet entered full menopause. I might have been having perimenopausal symptoms, as they're known, that indicated I was soon to enter full menopause. But it wasn't until I underwent the surgery that my periods completely stopped. A few weeks after the surgery, I began to notice night sweats and hot flashes. Afterwards, I developed vaginal dryness. I developed a decrease in my libido or my sexual appetite, and I also experienced a decrease in my energy and my stamina. After that, I developed changes to my hair and to my skin, and I think to my overall body shape. While I think it's kind of difficult to know whether the surgical menopause contributed directly to these symptoms, because I was already at an age where I might have been entering it anyways, I think that it did have some impact. So, Michelle, in a nutshell, can you tell us what we mean by menopause and why it develops generally, and what the signs and symptoms are?
Absolutely. And thank you for sharing your symptoms. I think that was a really good introduction and overview of many of the symptoms that women go through when they become menopausal or when they're perimenopausal. So menopause is defined as a year with no period. When that happens because there aren't a lot of eggs left, we call that ovarian reserve. And in Canada, the average age for most women would be about 51 and a half. But women who undergo treatment for cancer therapy, either chemotherapy or surgical treatment where the ovaries are removed, go through menopause at the time of their treatment. So even though we use a year of no period as a definition for menopause, that's not true for women where we know why they went through menopause, because they don't have eggs inside their ovaries anymore, and the eggs aren't making estrogen anymore. And many of the symptoms that women have in menopause are because of estrogen withdrawal. Some of them get better over time, and others get worse over time. So the things that you were describing that happened to you, it sounds like at the time of your surgery, your ovaries were flickering. They still had a little bit of estrogen in them, and they may not have been making a consistent egg every single month like they were when you were in your prime reproductive years, but you still had enough estrogen there that you were constantly exposed to amounts of that hormone that didn't make you feel symptomatic.
Okay.
As time goes on and the amount of estrogen in the eggs decreases and the quality of the eggs decreases, then you don't have the estrogen being produced and women become symptomatic. So hot flashes and night sweats, which we call vasomotor symptoms, are the most well understood and well known symptoms of menopause. But there are so many other symptoms that go along with it. So some women will have sleep disturbance, definitely changes in sexual drive or libido, like you alluded to. Some women have heart palpitations where they feel like their heart is racing or beating out of their chest, joint pains and joint aches, a change in energy and stamina, muscle weakness. That is usually something that takes time to develop, where the muscles become weaker over time. And then what we call genitourinary syndrome of menopause, and that's a long term, but that is a term that refers to all the things that happen to the lower genital tract: dryness in the vagina, irritating discharge, pain with intercourse, bleeding or itching, recurrent urine infections, or the sense of urgency or waking up at night to pee frequently. And you can imagine that all of these together don't help each other. So, peeing at night doesn't help your sleep, which is already being disturbed by menopause. And dryness in the vagina doesn't help your libido, which is already being disturbed by those hormonal symptoms. So it's this complex interplay of symptoms that tend to be really impactful for quality of life. And that is different and distant from the silent things that also go on in menopause, where the bones become thinner, or the cardiovascular system, like the blood vessels that go to the heart, start to change from that protection of estrogen and become more like our male counterparts as they age. So, so it's no picnic,
No, it's
but
not.
very understandable. Yeah.
Yeah, I'm trying not to get too depressed as you describe all of the symptoms. But listen, we know that there's something that can be done about this, and that's why we have you here. We will touch some more on some of the things that you've mentioned. But I wanted to ask you, is there a difference in the way some of these signs and symptoms are experienced if you undergo surgical or premature menopause versus the natural menopause, which doesn't sound too natural to me, but it is natural. It's part of life, I know.
It is. And I always say, the three things that are unavoidable in a woman's life are death, taxes, and menopause, because nobody gets away without menopause if they live long enough. And I try to think of it like I do my taxes, which is a privilege. Because if you got this far and you're
Yes.
going through menopause, then you're still here and you're still with us.
Yes.
But you're absolutely right. So induced menopause, which means menopause that happens because of some sort of a medicine or a surgery. So that could be surgical menopause where the ovaries are removed, or where chemotherapy puts the ovaries to sleep, which can be temporary or permanent, definitely has symptoms that are worse, so more severe and longer lasting than women who go through menopause spontaneously because their ovaries have just stopped working over time. Symptoms that take longer time to develop, like dryness in the vagina, those tend to be similar across the board, although worse for women who are taking medications that might suppress their estrogens further. And some women who have different types of ovarian cancer may take those types of medications as well. But the symptoms of surgical menopause or induced menopause happen earlier. So they happen at the time that the surgery or the medical therapy starts, and they tend to last longer and be more bothersome.
All right. And so you've referred in this last little piece to those symptoms being worse and more protracted or longer lived than, if those symptoms came about naturally. What about some of those more harmful effects that can take place for a woman who's undergone that premature menopause as a result of her treatment?
So, aside from the effects that treatment can have on the cardiovascular system, like certain chemotherapies can sometimes be dangerous for your heart muscle, and so forth, menopause before 50, but specifically before 45, can have impact on your long-term survival as well. So, things you may not be aware of happening because of that estrogen withdrawal are the bones can become weaker, and you can develop osteopenia, which is weak bones, or osteoporosis, which is even worse bones, which are more likely to fracture with less of an impact. Women develop earlier cardiovascular disease and are more likely to develop cardiovascular disease. So that could be things like heart attacks or heart failure when they go through menopause before 45. And women are more likely to develop dementia, so cognitive aging, brain aging, and Parkinson's because of menopause that happens before 45. And some of these risks are improved by taking estrogen therapy, but some of them may not be. Now, I know that probably sounds really scary, but let's keep in mind that all is not lost. These are risk factors for developing these diseases. So I like to think of this as a non-modifiable risk factor. That means that you had your surgery or your premature menopause or your chemo, and that's the lot in life that you have been dealt and something you can't change. But you do have the power to change things that are actually very impactful on your risk for bone disease and heart disease and Alzheimer's disease and cognitive decline. And those things would be things like trying to maintain a healthy exercise regimen or keeping a normal body weight, trying to minimize your alcohol intake and not smoking. You have diabetes, making sure that your sugar control is really optimized. And I always try and remind people that we have women walking down the street who've never faced ovarian cancer, let's say, who may not even be aware of these things and are just living that life without optimizing those modifiable risk factors. But because you know about them, this is actually something you can do.
Yeah, yeah. Thank you for framing it that way, because I think actually this whole podcast series is about trying to modify or change things that you can change, given, as you say, the lot that you've been given. It's all about taking control where you can take control. So it's very,
Exactly.
yeah, yeah. So you mentioned some of the lifestyle changes that can help prevent some of the long-term symptoms, but let's just jump back to maybe the symptoms, pardon me. So you were talking about long-term, maybe harmful effects, but the symptoms like the flushing and the sweats, those kinds of things. How can women who've undergone premature menopause manage them?
So women who undergo premature menopause, if they are eligible, should be offered and should take hormone therapy. And we think of this really as hormone replacement therapy because it's replacing the hormones that your ovaries should be giving you, but that were taken from you as part of your treatment. Before we talk about these medical managements, I want to talk about some of the lifestyle things that you can do because they're good for everybody. And even women who can't take hormone therapy can think about using some of these strategies for reducing their hot flashes and night sweats. So, in addition to the things we just said, the normal body weight, the alcohol minimization, and the not smoking cigarettes, there's actually evidence for cognitive behavioral therapy for helping with hot flashes and night sweats. That would be something you would learn as a strategy to cope with the symptoms. And you would work with perhaps a social worker or a psychologist who's trained in cognitive behavioral therapy to develop those strategies.
Okay.
Acupuncture has
Mhm.
evidence for it for helping with hot flashes and night sweats. And certain types of mindfulness and paced breathing can also help to help minimize the severity of the hot flashes and night sweats.
Okay, so just to summarize that, um, cognitive behavioral therapy is a practice that we can learn to help us get through these difficult times. Acupuncture, which that's really interesting that it's been shown to help with those symptoms of hot flashes. And then mindfulness-based practices, specific types of breathing that we can also learn by reaching out to maybe members of the team at the hospital. These tools can also help us get through these difficult times. All right.
Absolutely. And they would apply to everybody. So it doesn't have to be people who can or cannot take hormone therapy. These can be helpful as a way to improve the symptoms, regardless of why you've gone through menopause and regardless of whether you can take additional therapies or not.
Okay, great. Good. And aside from those lifestyle changes and behavioral practices, what else would you recommend?
So now we're going to sort of move into the medications or the pharmacologic treatments. And this is something that would be prescribed. And when it comes to treating the hot flashes, the night sweats, and some of the other symptoms we just talked about, we ideally would use hormone replacement therapy, but only for women for whom it's safe to do so. So some women have contraindications to hormone therapy. And certainly for the people listening today or viewing today, if you don't know whether you have contraindications or not, you would want to ask your physician. And if they don't know, because sometimes it's really hard and complex, then they could certainly refer you to a menopause specialist who might have a better understanding of whether it's okay to use hormones or not.
Michelle, what do you mean when you say contraindication to a medication?
So a contraindication means that there's something in your medical history that precludes or should stop you from taking a certain medication. So an example could be if you had an allergy to a component of a medication, that would be a contraindication. If you don't want to take something because you are uncomfortable with it, that could actually be considered a contraindication. But usually when we talk about it, we're talking about you have had something happen to you that should stop you from taking a certain medication. And a simple answer would be someone who has had breast cancer has a contraindication to taking a hormone therapy that could cause that breast cancer to recur.
Okay, thank you for clarifying that.
The types of hormone therapy usually involve some estrogen replacement. And then whether another medication is included depends on whether the uterus has been removed or not. So for women who have had a hysterectomy, which will be many women who've had certain types of ovarian cancer, then the hormone therapy is fairly simple. It's some sort of estrogen on its own. And the estrogen is really the hormone that helps with the hot flashes and the night sweats and many of the other symptoms. And that can be taken in many different ways that I'm happy to explain to you. If you still have a uterus, then you can't take estrogen on its own because estrogen on its own can lead to different types of uterine cancer. So you would need to take a combination of therapy that also includes a second hormone called a progestogen, and progesterone is going to be the most familiar one to you, and that would protect the uterus from developing uterine cancer. Now, there are some populations of women who can't take estrogen, but can take progesterone. That's going to be a really unique setting, but certain types of cancer are not safe to use estrogen in, but you can use progesterone. And in that case, there's a subset of women for whom progesterone on its own will also help with symptoms, but perhaps not as much as estrogen.
Okay, so it's important if you're a woman with ovarian cancer who thinks she might benefit from hormone replacement therapy to see an expert in this field so that she receives what is safe for her. And in other words, what is not contraindicated, or what is the best drug given the benefits and given the potential harms, because not all ovarian cancers are the same, right, Michelle?
That's right. So there are common, more common types of ovarian cancer. And most of us, when we talk about ovarian cancer, are talking about epithelial ovarian cancer and specifically high-grade serous ovarian cancer. Now, you might not know what kind of ovarian cancer you had, and you can ask your oncologist, certainly, and they'll be able to give you an answer. But the menopause counseling is really specific to the type of ovarian cancer you had. So for the usual high-grade serous ovarian cancer, there are actually good studies that tell us that using hormone therapy is safe after treatment and, in fact, may be beneficial for how long you live and for your disease-free survival. So the amounts of time between, God forbid, getting a recurrence of your ovarian cancer. However, there are other types of ovarian cancer that are less common, but can sometimes be more common in younger women who were not yet menopausal, like low-grade ovarian cancer. And those women actually take medications to block their estrogen, and it would be really not safe for them to take any kind of hormone therapy, despite the fact that they are more likely to be younger and premenopausal at the time of their treatment.
Okay. So I
And
find
perhaps I can say one more thing. I'm sorry to interrupt you, Alicia, but I don't want to have anybody coming who maybe went through ovarian cancer treatment in their postmenopausal years and saying, I should take hormone therapy because it's going to improve my survival. That's not the case. This is really for the treatment of symptoms or the protection of women who are under 50 or under 45 when they go through treatment.
Yeah, so that's a good point because now I'm in my late 50s, and as I was thinking about this, I was thinking, wow, you know, the positive effects sound really quite promising, but I kept having to remind myself, no, we're not talking about the age group that's post 50. We're talking about those women that had menopause arrive earlier than that age as a result of their treatment. And so, do we know from studies then in women in their late 50s and 60s that it makes no difference to their general health? I know we're probably entering a whole other ball of wax, but can you summarize that?
It's a great question. And I mean, the data would not be specific to ovarian cancer survivors, but for women who are above the average age of menopause and who are not necessarily symptomatic from menopause, but who are wondering about using hormone therapy for prevention of heart disease or for prolongation of survival, then that would not be indicated. So for women who are more than 10 years from their final period, or women who are in their perhaps 60s and beyond, the hormone therapy can actually be more dangerous, more likely to develop cardiac problems. The idea being that the further out from menopause you get, the more likely there are to be changes in your blood vessels, where the estrogen exposure after the changes can be dangerous.
Okay. Okay,
And
thanks.
actually, the US Prevention of Chronic Disease Task Force just came out with a reiteration of their statements that say that hormone therapy in menopause is not to be used for prevention of chronic diseases.
All right. Okay, so that's pretty strong. Yeah. Yeah, because I think over the last couple decades, it's been a question mark. And I also find very interesting, if I understood correctly, that in those women who can get hormone replacement therapy that are younger, that the time between recurrences is longer. Is that what you said? Yeah.
That was one of the conclusions of one of the randomized control trials that were done.
And
So
that,
again, I wouldn't suggest you take hormone therapy if you're above the average age of menopause and not having symptoms in order to improve your disease-free recurrence, but
yeah.
more that for younger women, they can be comforted by the data that in women with high-grade serous ovarian cancer, premenopausally, who take hormone therapy, there does not seem to be a negative impact on their cancer recurrence risk.
At least we know that's the message you want to drive home, probably. Yeah. Yeah. Okay. Um, so it shouldn't be harmful, generally speaking, in the more common group of women with the high grade epithelial ovarian cancers. What about women within that cancer of ovarian, the category of ovarian cancer who are BRCA1 and 2 mutation positive? Is it also safe in those women?
So those women are going to potentially have gone through menopause at a younger age because they will have either potentially developed ovarian cancer younger, or they may have had risk reducing surgery preventively to try and reduce their risk for ovarian cancer. And even among that group, some of them may have found cancer at the time of that preventive surgery that they weren't expecting to find. Now, they're a complicated group of women to treat because they also have this high risk of breast cancer, and they have potentially found out about their mutation because they themselves developed breast cancer at a young age. So, breast cancer is a contraindication to using hormone therapy, and that's true for any kind of breast cancer, whether it's hormone sensitive or not. For the most part, women who have had breast cancer are not supposed to use systemic hormone therapy for hot flashes and night sweats. And I specify systemic because that's not necessarily true for the treatment of the symptoms in the vagina and the lower genital tract that we talked about before. So if the woman who is a BRCA carrier and who had ovarian cancer or who had surgery preventively premenopausally has not had breast cancer and has no other contraindications, it would be considered safe for her and recommended for her to use hormone therapy because the risk of breast cancer is not thought to be significantly increased from using hormone therapy. But if she has contraindications to hormone therapy, like a previous diagnosis of breast cancer in herself, not in a family member, then she should not take hormone therapy. And we would be looking at the other non-hormonal medications for treatment.
All right. So if a younger woman receives a diagnosis of ovarian cancer, and then it's determined that she has one of the BRCA mutations, she undergoes a treatment for ovarian cancer, which includes a surgery and the chemo, then it would be indicated, as long as she hadn't had a history of breast cancer, for her to receive hormone replacement therapy.
That's absolutely correct.
Okay. All right. Okay. Good to know. Let's see. Now, we talked about what you referred to as genitourinary syndrome, and you described some of the symptoms of that, and they pertain mostly to what's happening down below, vaginal dryness, pain with sexual activity, and you talked about hormone replacement therapy by mouth. Did you expand on the topical, meaning replacement of hormones that can take place inside of the vagina? Can you expand on that a little bit more?
Yes, no, that's not something that we talked about yet. So there's a big difference between systemic hormone therapy, which is hormone therapy that you would take by mouth or through the skin for the treatment of hot flashes or night sweats, or for the prevention of those other diseases in early menopause or premature menopause. But anybody who has symptoms of genitourinary syndrome of menopause, the dryness, the itching, the discharge, the pain with sex, the urinary symptoms, can be treated for those symptoms at any stage of their lives. And there are very few, if any, contraindications to using local treatment, so treatment where the symptoms are actually happening, for menopausal genital symptoms. So our options for those women are to use local estrogen therapy, and that could be estrogen creams, that could be estrogen tablets, or that could be an estrogen ring in the vagina. And then we're quite fortunate to have had 2 new products come to the market in Canada this year. One is an oral treatment, so a treatment by mouth, a pill that you would take for treatment of vaginal dryness. And the other is a daily ovule that you would insert that is made out of a weak testosterone called DHEA, that is also useful for the dryness in the vagina and those other concomitant symptoms. And what's nice about that second medication is it actually has no black box warnings on it, which means technically you can use it without any concern about your own medical history. So we always take every risk into account, and we have conversations about your individual risk factors. But when you open that product and you read the product monograph, there is no black box warning that says if you've had cancer, you can't use this product. And that's actually quite unique. Yeah, and that's fabulous. And I think it's a good opportunity to also say that if you're not comfortable with the idea of using these hormonal treatments, either by mouth or locally in the vagina, you can also use non-hormonal treatments, which can be helpful as well. So there are moisturizers, either glycerin-based or hyaluronic acid-based, the second of which actually draws water to the wall of the vagina and improves the objective water content in the vagina. So it's not just putting cream on your vagina, it actually is drawing water molecules to the vagina to help with that dryness and that sensation of dryness. And those are non-hormonal and available over the counter.
Okay. And so would you apply those on a regular basis, or would it be just prior to sexual intercourse, or both?
All of these would need to be used preventively. So either the estrogen treatments, the testosterone treatments, or the moisturizers, you would want to use regularly to improve the health of the vagina and the daily sort of sensations. But if you're also trying to have intercourse, I try and remember that intercourse, particularly when you're postmenopausal, can be quite a traumatic event. There is a lot of friction that goes on with penetration inside the vagina, and you need the walls of the vagina to be well lubricated for it not to hurt. So if you have your own lubrication, that's great. But if you don't, there is absolutely no shame in using lubricants as well. Some people buy lubricants at the drugstore, and I would encourage you to use either water-based or silicone-based lubricants because they're a little bit more slippery. And other people have a lot of success with something that they might have in their home, like coconut oil, which is very bland and very moisturizing and can be used for a sexual lubricant or a personal moisturizer as well.
Okay. Today I went to get some notes printed for this podcast because my printer is not working at home. And the woman that handed me the printed notes I guess she'd taken a look at them, and she was postmenopausal. I think she's otherwise healthy. And she described how, difficult it's been for her to have sex, that it's a real, and I think it's a big problem, as you say, just to emphasize that. Just up until today, I was reminded of it, not only myself, because there were challenges there, but also, just in the general population, whether you've had cancer treatments or not. So I think it's something that we should all feel a little more comfortable speaking to our physicians about, or just, to our partners about, in order to help us in this, important area of our lives. Are there some trade names that you might recommend for the lubricants?
Yeah, if that's okay. So one of the trade names for the hyaluronic acid ovules that you could get is called Repagyn. That's Repagyn. And that would be an ovule that you insert regularly to help with moisture in the vagina. And then the two hyaluronic acid moisturizers that you could use are called Zestica, Zestica, or Gynatrof, Gynatrof. Those are moisturizers and not necessarily sexual lubricants. The sexual lubricants that I would recommend are, as we said, coconut oil, or Uber Lube is a silicone-based lubricant. Slippery Stuff is a silicone-based lubricant. And there is a brand of products called Cleo, Cleo, that are also quite natural and have a lot of good moisturizing ingredients in them. I usually stay away from the other water-based lubricants that you may have heard about perhaps while you were younger and using condoms and you wanted to not use an oil-based lubricant, because they do get a little bit stickier over time. But technically, any lubricant you like should be fine.
Okay. With regards to the testosterone intravaginally that's inserted into the vagina, is there any effect on libido if it's inserted just into the vagina versus if you take it by mouth?
So there wouldn't be a systemic impact on libido, but let's remember that libido is really multifactorial, right?
Yeah.
So there are big biological differences between men and women tend to need most things in their life to be going fairly well for them to want to have sex. Women need to be sleeping well. They need to have their self-esteem and their body image as well controlled as possible. And that can be hard for women who have had big surgeries and might have big incisions or concerns about the way they look now compared to prior to treatment. They might be concerned because in menopause, they put more weight on around their abdomen, and that makes them also not want to have sex or not want to be seen by their partner. They may have lost their hair during chemotherapy, and that can impact their body image and result in a decrease in their sexual appetite as well. If sex is painful, you will never want to do it, no matter how attracted you are to your partner, because we're conditioned to not want to do things that are painful. It doesn't make sense, right? So we have to treat vaginal pain and make sex pleasurable before we can even talk about improving sexual desire.
Okay. That's a point well taken. Yeah, it's a simple question, but not a simple answer, that's for sure. And I guess it requires time and asking many questions to see which of those factors you've mentioned affect a woman's ability to enjoy sex. Yeah. I think also maybe it's difficult for the partner sometimes when the partner knows that that the woman is undergoing these emotions and bodily changes and all the rest of it. So that enters into it too. Yeah.
Absolutely.
Okay. Gosh, well, I've gone through most of the questions that I had intended to ask you, Michelle. Are there any other points that you wanted to raise up to people that might be listening? Perhaps you can tell us a little bit about the clinic that's offered at Women's College. I was quite impressed to learn about how specialized the clinic is, and how how women going there can be assured that they're receiving really great advice to help them through what can be a very difficult time in their lives.
Thank you for saying so. I would be very happy to talk about two clinics that I think are pertinent. And then also, the one thing I think we didn't discuss that may be worth a mention is if you do have a contraindication to using hormone therapy, there are medical treatments that can help with hot flashes and night sweats and bone protection that are not hormonally based. So again, you could be referred to a menopause specialist to talk about what options might work best for your individual symptoms, and also keep apprised of the fact that there are new treatments that are currently waiting for approval in Canada that should be as effective as low dose estrogen in treating hot flashes and night sweats, but are not estrogen based. And that's very exciting for menopause specialists like myself, because we have really been limited up until now in terms of using other medications that have a side effect where hot flashes are improved. Whereas this would truly be a medication that is targeted towards the treatments of hot flashes in women who have had a contraindication to using hormone therapy. When it comes to the clinics that I participate in at Women's College, the two that are really pertinent here and that I think provide important service are our FOCC, which is our Familial Ovarian Cancer Clinic. And that clinic is meant for women who are diagnosed with a genetic mutation that predisposes them to developing ovarian cancer, plus or minus other cancers like breast cancer. And commonly that will be BRCA1 and 2 mutation carriers, but there are other genes as well. And when you come to our clinic, you can come as soon as the diagnosis of carrying that genetic mutation has been made, because we'll talk to you about things like contraception, like family planning, the opportunities to look at fertility treatments where we can even screen out for the gene by doing certain types of IVF and fertility treatment. And then when the time is right, we talk about planning for surgery. We do the surgery, and then everyone who has surgery with us is enrolled in the aftercare clinic if they have menopausal issues, where you'll be seen by somebody like myself who is specialized in treating menopausal symptoms in women at high risk for breast and ovarian cancer, as you may have gone through cancer at a younger age, or treatment for menopause and cancer treatment at a younger age. The other clinic that has really evolved out of a need is I now do a once monthly after gynae cancer clinic. So this is a clinic not necessarily for women with genetic mutations, but women who have had any kind of gynecologic cancer, ovarian, high grade, low grade, contraindications to estrogen, not contraindications, cervical, premature, not premature, but still suffering, where nobody's really quite sure how to manage your menopause best. We really try and take an evidence approach and a very individualized approach to managing your menopause.
Okay, so sorry, the name of that second clinic is
It's just called the After Gynae Cancer Clinic. But if you get referred to me at Women's College with a history of a gynecologic cancer, and primarily these referrals come from our oncologists at Princess Margaret and at Sunnybrook, but certainly anybody can refer you, then you will be scheduled into that clinic where all the women we see that day will have had some form of gynecologic cancer and now are suffering with some type of menopause issue.
Okay, so if the referring doctor provides the correct information to your hospital, then the patient can be rest assured that she'll be placed in the right clinic.
Correct.
And I also want to give you the opportunity to briefly tell our listeners about all the great research that can come out of these clinics too. I mean, not only are you providing a really good service for individual patients, but this also, all the information that you're gathering and studying also helps us understand better how to help women with gynecologic cancers in the long run.
Absolutely. So we're always involved in research studies, either international involvement where we're part of a larger study or smaller studies that we do on our own, trying to answer questions that we think will really make a difference clinically in a patient's life. So part of my interest is in translational research, and that's what I did my master's in. So the research that I do tends to really answer a question that might make a difference in the actual patient care that we provide. So some examples of that are we are collecting symptom data for women who have had their tubes and ovaries removed before menopause and are either given hormone therapy or are not, and to see what different hormone therapies have an impact on the different types of menopausal quality of life symptoms. We're doing a study looking at whether taking the fallopian tubes out on their own before the ovaries leaves any ovarian remnants of fallopian tube tissue. So we want to know, if we just take tubes out before women are ready to have their ovaries out, have we done enough in terms of removal of every little microscopic piece of fallopian tube tissue? And then, as I said, we are participating in some larger studies looking at, for example, aspirin therapy as a preventive agent for ovarian cancer, or another type of study looking at whether fallopian tube removal before ovary removal is an acceptable approach to lowering the risk for ovarian cancer.
Great. So good to know. All right. Well, it's been a real pleasure speaking with you, Dr. Michelle Jacobson, obstetrician gynecologist and menopause specialist at Women's College of Mount Sinai Hospitals in Toronto. I hope that our listeners have enjoyed this podcast as much as I have, and have learned a substantial amount, as I have as well. So have a great day, everybody.